You know how when you get a cut, it usually scabs over and heals in a few days? Well, what happens when it doesn't? Today, we're going to dive into a hidden medical crisis that affects millions of people, the chronic non-healing wound. It's a huge problem, and it's tied to really common conditions like diabetes and obesity, turning the body's natural repair process into this really complex medical mystery. So, let's get into it.
So what is the actual difference between a scrape that closes up in a week and a sore that stays open for months or, even years? Why does our body's amazing ability to heal itself sometimes just shut down? That's the big question we're going to unpack right now.
And look, the stakes here are incredibly high. For some patients who have these chronic wounds and poor circulation, the risk of a major amputation can shoot up to 40%. And that's within a single year if it isn't handled correctly. This is not a small thing. We're talking about a condition that can absolutely change someone's life forever. Okay, so to get why this goes so wrong, we first have to understand how it's supposed to go right. The best way to think about normal wound healing is like a perfectly managed construction project, right? There's a clear blueprint, different crews of workers show up exactly when they're supposed to, and each team finishes its job before the next one even arrives on site. And this whole project has 4 clear phases. First up, hemostasis. That's the emergency crew that rushes in to stop the bleeding. Then you've got inflammation. This is the demolition crew, clearing out all the debris and damaged stuff. Next is proliferation. Now the builders come in to lay down a new foundation. And finally, remodeling. The finishing crew comes through to strengthen and reorganize everything. It's this beautiful, orderly sequence.
So here is where we find the real problem. A normal, acute wound follows that perfect construction plan. But a chronic wound? That's a construction site in total chaos. The whole process gets stuck, and almost always, it's stuck in that inflammatory phase. So just imagine, the demolition crew shows up. And then they never leave. They just keep tearing things down, creating this toxic environment where the builders can't even get started.
And if that wasn't bad enough, the very cells that are supposed to be doing the repair work, these cells called fibroblasts, they can get old and just, exhausted. The technical term for it is cellular senescence. It's like the construction workers on site are just too tired to listen to the foreman. They grow super slowly, and they basically ignore all the signals telling them it's time to rebuild.
So, we know the healing process is stuck in this massive traffic jam. But what's causing it? Turns out, the answer often isn't in the wound itself. It's usually hiding in the patient's underlying health conditions. For the most part, limb ulcers fall into one of 3 buckets. You've got venous ulcers, which are caused by faulty veins, and the fix for that is compression. Then there are diabetic foot ulcers, which come from nerve damage and pressure, so the key there is getting that pressure off the foot. And finally, arterial ulcers, which are from bad blood flow, and that requires restoring circulation. The huge takeaway here, you absolutely cannot treat these the same way. Getting the diagnosis right is everything.
And of course, just to make things more complicated, it's often not just one single problem. In fact, for more than 20% of patients, that's more than 1 in 5, there are multiple things going on at once. You might have someone with both diabetes and bad circulation. And that's why these specialized wound clinics are so important. They have all the different experts needed to untangle these really complex cases.
So, no matter what the root cause is, there is a universal first step that has to happen before any of the cool advanced treatments can work. It's a strategy called wound bed preparation, and it's all about creating an environment where healing is actually possible again. The goal here is, it's pretty radical actually. The most important part of prepping the wound is debridement, and that's the physical removal of all that dead, non-viable, exhausted tissue. You're basically clearing out that entire stalled construction site and telling the body, okay, let's start over from scratch. You're literally trying to turn a chronic wound back into a fresh, acute one to reset the healing clock. Another major thing to clear out is something called biofilm. This is a slimy protective shield that bacteria build for themselves. Think of it like an invisible fortress they build right there in the wound. It stops the body's own immune system and even antibiotics from getting to the bacteria. And this biofilm is what keeps fueling that chronic destructive inflammation that keeps the wound stuck.
All right, so once the cause is identified and the wound bed is prepped and ready to go, what's next? Well, this is where a really incredible set of modern tools comes into play to kickstart the healing process.
And we're not talking about just putting on a new bandage. This is some seriously advanced stuff. We've got negative pressure wound therapy, which uses a vacuum to pull the wound together.
hyperbaric oxygen chambers that supersaturate the tissue with oxygen, advanced skin substitutes made from living cells that act like a scaffold for new growth. There are even specific growth factors you can apply that are like direct instructions to start rebuilding.
And this stuff really works. Take that negative pressure wound therapy, or NPWT. In a big study on diabetic patients who had a partial foot amputation, 56% of the wounds treated with this therapy were totally healed after 16 weeks. Compare that to just 39% for those who got the standard treatment. That's a huge difference.
Here's another great example, bicaplermin. It's a gel that's packed with a specific growth factor. When they looked at studies on diabetic foot ulcers, 50% of the patients using this gel healed up within 20 weeks. For patients using a placebo gel, it was only 36%. So it just goes to show how these targeted therapies can really move the needle.
But here's the thing, none of these amazing tools work in a bubble. The absolute best results happen when you have a whole team working together, when vascular surgeons are talking to podiatrists who are working with endocrinologists. Managing these patients is complex, and it really does take a village.
All right, we have covered a lot, from the biology of cells all the way to some really high-tech medical gear. So what's the big picture here? What's the main thing to walk away with?
I think the most crucial thing to understand is this. Healing a chronic wound isn't about finding some single magic bullet or a magic dressing. It's a complete paradigm shift. You have to stop treating the hole in the patient and start treating the patient with the hole. And that means you have to follow a system. First, you diagnose the real underlying cause. Then, you prepare the wound bed to reset that healing clock. And only then can you really use these advanced therapies to get the job done.
And that all leads us to one final and honestly really critical question. We are getting better and better at treating these incredibly complex wounds. But as our population gets older and as rates of things like diabetes keep climbing, the real challenge for the future is going to be this. How do we shift our focus from just treating these wounds to actually preventing them from ever happening in the first place?